Welcome back to CLOT Conversations, the show where we dive deep into the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by our host, Dr. Jamil Abdurrahman from Toronto General Hospital. Get ready for another fascinating episode covering the latest research. Thank you to Cardinal Health for their unrestricted support of this episode, and thanks for tuning in.
In this episode, we will be discussing a publication recently developed by Thrombosis Canada, Orthopedic Surgery VTE Thromboprophylaxis Guideline Summary. We're pleased to have one of the authors join us today, Dr. Marc Carrier.
Dr. Carrier is a hematologist and head of the Division of Hematology at the Ottawa Hospital, a professor in the Faculty of Medicine, Department of Medicine, and senior scientist in the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. He holds a clinical research chair in venous thromboembolism and cancer from the Faculty of Medicine at the University of Ottawa. He is also president of Thrombosis Canada. Thanks for participating in our podcast, Dr. Carrier.
Thank you for having me, David.
I'm going to start by asking you, what are the limitations with the currently available guidelines for VTE thromboprophylaxis with orthopedic surgeries, and how did that motivate you and your co-authors to create this document?
Well, we really wanted to have a multidisciplinary approach. So myself as an hematologist, Lena Chamberlain as a registered nurse, and Dr. Parvizi as an orthopedic surgeon really wanted to meet up to have a look at how do we look at venous thromboembolism prevention in this high-risk population. And as you alluded to, there are a number of different guidelines available, all looking at the issue in a different way. So we wanted to summarize all the different guidelines together and also provide a pragmatic approach of how do we incorporate that into clinical practice in a hospital setting or in a more community-based setting.
So with these orthopedic procedures, how can we preoperatively assess the thrombosis and bleeding risks in an individual patient?
Yeah, it's an important unmet need. And we really tried to find different ways to help clinicians identify who's at higher risk of having VTE, and therefore we be a bit more aggressive with thromboprophylaxis or pharmacological thromboprophylaxis, and also try to help clinicians say, well, who may be at high risk of bleeding or having trouble? And in this patient population, maybe mechanical thromboprophylaxis would be desirable. Unfortunately, we didn't really find any risk assessment model that could really tailor the patients according to their underlying risk of either VTE or bleeding. But we tried to summarize the different risk factors associated with VTE. So we made a table with patient-related factors, medical conditions, medications, procedure-specific factors that clinicians should think about when they're seeing a patient and then considering providing thromboprophylaxis. And then we also did the same thing with bleeding assessment, trying to highlight different characteristics. So patient factors, advanced age, obesity, procedure-related factors that may be associated with high risk of bleeding, medical conditions, as you know, like gastrointestinal ulcer, hypertension, chronic kidney disease that could increase that risk too. Trying to provide the clinicians with the risks and benefit, and then making the proper decision about pharmacological or mechanical thromboprophylaxis.
Okay. So what are our options for pharmacological thromboprophylaxis?
Yeah, it's funny because, we used to think that a lot of these orthopedic surgeries were really at very high risk of venous thromboembolic complications. And over time, as surgical techniques are improving, people are mobilized early, we're trying to mitigate any complications. Things have been changing, and sometimes the research has a hard time keeping up with these changes. So when we looked at the literature and all the different clinical practice guidelines, obviously low molecular weight heparin can be one of the options at prophylactic dosing for different types of procedure. Directal anticoagulant at prophylactic dosing or low dose can be. And now we're starting seeing aspirin as well as an option for different indication, sometimes following after a few days of anticoagulant thromboprophylactic dosing, and sometimes right away, and trials are ongoing. recruiting participants and patients, so we'll have more data in the near future.
And how about for mechanical thromboprophylaxis? What are options there?
Yeah, so mechanical thromboprophylaxis we can use either in isolation if you have a high bleeding risk patient, or in combination if you have a really high thrombotic type of patient. And often we would use two things. The first thing that you can do is graduate compressive stockings. They need to be properly fitted and sized for patients, and that will help to avoid venous pooling and may help to avoid venous thromboembolic complication. And what is often used during hospital stay is intermittent pneumatic compressions. Now, these also need to be fitted, properly sized, and kept most of the days, but these would provide compression to the legs and avoid venous stasis and hopefully avoid any potential venous thromboembolic complications.
Okay, so you mentioned in patients at high bleeding risk, you'd consider more so mechanical thromboprophylaxis. Are there any instances where you consider using both mechanical and pharmacological thromboprophylaxis?
hmm So sometimes if you have a very high thrombotic type of patient for which has previous history of VTE or recent VTE event for which you need to do an orthopedic surgery, then using pharmacological thromboprophylaxis combination with, for example, intermittent pneumatic compression may provide additional benefit in that certain setting. And there's data in other settings that have shown that in a very high risk patient population, combination of both pharmacological and mechanical prophylaxis can be very helpful to avoid venous thrombosis complications.
So in general, how should we approach thromboprophylaxis for a hip fracture?
Yeah, so for a hip fracture, there's not a whole lot of data, as you know. It's really an unmet need, but there's trials ongoing that will help. If you look at the current clinical practice recommendations, it's based on the data, and it's usually the recommendation would be with parenteral prophylactic dosing of anticoagulants, so low-molecular weight heparin or fondaparinux. Really, these are uh, the two types of agents for which there are randomized controlled trial data. But as you know, low-molecular weight heparin is parenteral, can be costly, and people have been looking for alternatives. And sometimes people are using rivaroxaban at a dose of 10 milligram once a day or a low dose DOAC, extrapolating data from total hip arthroplasty. And some people are even looking at ASA. So there's a trial ongoing called HipPro based in Calgary, randomizing patients to rivaroxaban 10 milligrams PO daily or ASA in that patient population. So that may help us figure out if we can use an oral agent for hip fractures. But for the time being, because of the lack of data, most clinical practice guidelines would recommend low dose parenteral agent.
Okay, and how about for hip or knee arthroplasty? How should we approach this?
Yeah, so this, as I mentioned before, the techniques have change a whole lot, and patients are mobilized very early after the procedure. And we used to use a lot of parenteral low molecular weight heparin in that setting for 14 to 30 days, depending if it's hip or knee arthroplasties. The EPCAT2 has shown that aspirin probably has a role in that setting as the risk of underlying VT seems to decrease over time because of better surgical technique and early mobilization. And there's an ongoing ETCAP3 trial randomizing patients to aspirin on the day of the procedure or rivaroxaban 10 milligram PO once a day. And that will help us to figure out if we can use aspirin and rivaroxaban in that setting from day one. Currently, clinical practice with guidelines would say you probably should use 5 days of low dose anticoagulant, low molecular weight heparin, or rivaroxaban 10 milligrams PO daily before using aspirin. But hopefully, the EPCAT3 will help us figure out if the risk is low enough so that we can use aspirin from day one.
Yeah, that's very helpful. So is there anything that we haven't discussed today that you would like to add?
No, I think this is a very interesting, changing landscape as surgical techniques are improving, as new agents are being available. The risk of thrombosis is changing over time. So it remains a very active subfield of thrombosis for research. and hopefully summarizing the current clinical practice guidelines, providing risk factors in the tables to help clinicians, giving some insights on how to pragmatically include that in your hospital setting will help the clinicians through this Thrombosis Canada document.
Marc, I wanted to ask you one other question, and that is, who do you think should read this document? Who is it really would it be valuable for?
Oh, I think it would be very valuable for all the surgeons as they make often the decision about thromboprophylaxis, the type, the agent, and the duration. All the learners that are going through as well their training, because that will provide them with insights. And I think the nurses should read it. And we really have a section in the document on practical approach and trying to really capture this in the context of the Operating Room Nurse Association of Canada and the Association of Perioperative Registered Nurses, really trying to provide an approach on how to incorporate that into clinical practice and provide a little bit of future directions on how to incorporate it.
Well, that's great. Thanks for your insights and review of the publication. We will be posting, or we have already posted this publication on our website, so it's accessible. I'll be including a link to the publication in the notes for the episode as well. And thanks, everybody, for the great discussion. For more information, check out the recording of the webinar on thromboprophylaxis that we held earlier this year. And again, thank you to Cardinal Health for their support for the Thrombosis Canada mission. Thank you to our audience for joining us on CLOT Conversations. We love hearing from you. To send your comments, questions, and ideas for future episodes, info@thrombosiscanada.ca. And want to stay up to date on the latest in thrombosis, hit the subscribe button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference. Your support matters, and so please consider donating to Thrombosis Canada.